welcome to this basic introduction to FDG PET-CT scanning. This is my favorite topic because PET-CT is essentially high-tech killing, so it doesn't get more fun than this conversation and topic. We take this technology for granted in the United States, however, many countries have poor access, even the developed ones, and this has a lot to do with difficulties in producing and delivering FDG to each machine. A few years ago, I was actually astounded to read an article on BBC describing installation of PET-CT. This would be unimaginable for CNN or Fox News. So today we're going to talk about basic principles of PET imaging, tracer production, quantification, interpretation, applications of PET-CT, as well as treatment response assessment. So the reason I like PET-CT is because it's easy, as you see in the top row. Pre-treatment tumor is bright, post-treatment tumor is not bright, so we can assume that there is a complete response. So 3 seconds later we can deliver an interpretation and return to important things like coffee or tea. But before we can get there, we need to talk a little bit about production of F-18. F-18 is fortunately produced in a cyclotron, which is a lot easier to deal with than a nuclear reactor. And this is where the negatively charged hydrogen ions accelerated where they hit the oxygen-18 enriched water to produce F-18. Then F-18 itself will decay into the oxygen-18 and positron, which is an anti-electron and neutrino as well. And the decay half-time of F-18 is 109 minutes, which makes it essentially an ideal isotope. It's long enough that we can deliver the dose to an imaging site, but yet doesn't stick around for days, so the radiation amount that's delivered to the patient can be reasonably controlled. When it comes to tumor uptake of FDG, it occurs via the glucose receptors, and FDG for all purposes simulates sugar, and we like sugar, tumor likes sugar, so most of the tumors will gladly take up FDG thinking that it's glucose. Now, in the brain, glucose uptake is insulin independent. In muscle, in muscle, glucose uptake is insulin dependent. So in ideal state, we're striving to achieve euglycemic hypoinsulinemic state so that our FDG is not driven into the muscles. Once FDG gets into a cell, it becomes phosphorylated and becomes trapped, enabling accumulation of FDG within the tumor. Some tissues, however, are really, really smart, and that's, for example, kidneys, and they can tell the difference between the glucose and FDG, and that's why FDG is excreted into the urine. So many renal tumors are smart enough again, and they can tell the difference between FDG and glucose, so they will not take it up. These are some of the most important questions when it comes to practical reality of performing PET scans, not just reading the scans. So we're going to talk about fasting, hydration, blood glucose levels, what to do with diabetic patients, what is the typical dose, what is the delays, and we'll talk about contrast, both oral and IV. We know fairly well that FDG uptake of tumor is really blood glucose dependent, and we can see based on this animal experiments is that the uptake really declines with levels below 100 and is really proportional to the concentration of glucose in the blood prior to that. We also have some human experiments that were performed in Finland. I would imagine that modern IRB would have an investigator arrested, but nonetheless we have this in the literature. So these patients underwent FDG PET-CT with the same dose, with glucose loading and fasting state, and not surprisingly we see that the SUV max of the tumor is dramatically lower after the glucose loading, which confirms the previously demonstrated animal experiments. And these experiments and general experience forms the basis for our recommendations for blood sugars. So typically we try to have the patient fast for at least 4 to 6 hours to decrease the blood sugars and make sure that the patient is hypoinsulinemic. Again, our goal is hypoinsulinemic euglycemic. If the patient is euglycemic by hyperinsulinemic, which will occur after a recent meal, the FDG will be driven into all of the skeletal muscles, leaving much less of it available for the tumor. So, in terms of hydration, water works, coffee works, tea works, but sugar-containing beverages do not work. So, juice is a major problem. Coca-Cola, Pepsi-Cola is a huge problem. So, in the past, we used to train front desk staff to spot a patient that's walking in with a large glass of juice or a soda. For blood sugar, we really prefer the blood sugar to be under 150 and are willing to accept blood sugars up to 200 with image deterioration above 200. In the remote past, I used to be young and smart and idealistic, so I really put my foot down and said, well, if blood sugar is 210, let's bring the patient back. And every time the patient would come back with a blood sugar even higher. So in the recent years, I've given up that pursuit, and I just realized that blood sugar reflects where the patient is, and they're not going to do anything different for the scan. So for diabetic patients, there are two strategies. One is the more traditional one, to do the scan in the morning before the insulin, meds, and food. And this ensures some sort of semblance of euglycemic, hypoinsulinemic state. However, in my experience, this is when the blood sugars tend to be the highest as well, so the success is modest. For patients that are slightly more compliant, the better strategy is to do the scan at noon, right before lunch, so the patient would have the morning dose of insulin as well as the breakfast, and then to be scanned at least 4 hours after the breakfast before the lunch. And that strategy usually results in the lowest blood sugars in a diabetic patient. For patients on insulin pumps, that requires a whole different discussion. For FDG, the typical dose is 10 millicuries, and this is the conventional scanner, time of flight. The time of flight equipment allows us to significantly reduce the dose, which is important for pediatric patients. Scan delay, we generally allow 60 minutes after the injection to allow the tumor to take up the FDG and to allow the kidneys to clear the blood pool and soft tissue FDG uptake. So right before starting the scan, we ask the patient to empty the bladder to minimize amounts of FDG with urine within the pelvis. Contrast, personally, I'm a big fan of both oral and IV contrast for the PET-CTs, just because it really helps us identify anatomy and see tumor. The downside is it does interfere with calculations of SU max, which we'll see later. However, I think the advantages of seeing the tumor far outweigh the disadvantages. I think this is especially important for head and neck PET-CT, where without contrast, it's really, really hard to see anything. All right. So these are just some pictures of the PET scanners, and the very first picture is the original, one of the early PET-CT scanners, and it's just, subsequently in the late 90s, early 2000s, some bright individual combined CT and PET gantries, and then PET-CT was born, which really resulted in demise of nuclear medicine as a freestanding specialty because it required detailed anatomy of CT. More recent advances included PET MRI machines. One from Philips just put an MRI gantry and a PET gantry in the same room with a table in between, and subsequently Siemens developed a machine that simultaneously acquired both PET images and MRI images. A more recent development came from a company called United Imaging. It's a Chinese manufacturer that created a whole body PET machine that has 194 centimeter long imaging gantry. So that's essentially enough for every patient, except perhaps some of the professional basketball players, but in reality, even in them, if we get it up to the knee, that's more than enough. What they say is that you can actually get the entire scan in about 3 minutes, which is extraordinary, or do a continuous scan to allow truly fully quantitative imaging. This technology is extremely, extremely exciting, so I can't wait to see some publications and research based on these machines. Crystals, like every other technology, there has been evolution in the crystals, and they have gotten better. For the purposes of this talk, you should just be aware that crystals exist, they're important, and be familiar that at least there are names like LSO, BGO, and GSO out there. The basis for PET imaging is the F18 emitting positron as it decays to oxygen, and that positron, upon hitting an electron, emits a pair of 511 keV gamma rays that will be hitting detectors at the same time. So PET relies on coincidence detection, meaning detectors on the opposite side of the gantry are triggered, so we're able to draw a line in between, not just a point as with the gamma camera. So coincidence imaging significantly decreases the speed and then increases the accuracy of exam, and also with time of flight technology we're able to calculate exactly where on that line the annihilation event occurred. Therefore, we can either acquire the images dramatically faster with the same dose or significantly decrease the dose for pediatric population. Similar to all other nuclear medicine imaging as well as radiology, we can use collimators to increase the spatial resolution and decrease noise, or we can use fully 3D imaging with no scepter, and that enables us to acquire data faster. For a while, there was a significant debate about it, and there was some great work done by Martin Lodge from Hopkins, who clearly showed that abundance of signal far outweighs the benefits of collimators, and you can see the images on the left with collimators and images on the right without collimators, and these were practical, realistic clinical exams, and even without any physics to any observer, the images on the right are much better. So this is currently the standard of imaging. Most of the PET scans are done in 3D mode. However, no technology is perfect, and there are certain spatial localization problems. In reality, based on the physics, the spatial resolution of PET is limited to about 5 to 7 millimeters. However, that doesn't mean that we can't find a really small tumor. If we have a lot of FDG uptake or another tracer uptake, let's say in the prostate membrane-specific antigen PET for prostate cancer, there is such a rich amount of targets that it's possible to pick up tiny several millimeter lesions using the tissue resolution advantages. So in PET technology, because the positron travels a certain distance, it creates something that's called positron range blurring. Subsequently, once the annihilation event occurs, the 511 keV photons travel at a certain angle because of the conservation of momentum law, and this is called annihilation angle blurring. So taken together, these result in about 5 to 7 millimeter spatial resolution. Radial blurring is another artifact that occurs at the edges. With every imaging modality, being in the center of the gantry is better. Once we get closer to the edges, we can have non-uniform penetration, and that will decrease the spatial resolution of the exam. PET tends to, during 2000s, as Medicare was deciding whether to pay for the PET scanners or not, they did a huge national registry and surveyed the oncologist and referring clinician at the diagnosis, initial staging, restaging, and suspected recurrence. And use of PET scan in each of these cases resulted in major changes of management in about 1/3 of the patient. So with that data in mind, Medicare and subsequently other insurances decided to widely cover the PET CT. A typical oncology protocol using a conventional machine, patient receives an injection of about 10 millicuries IV. Subsequently, patient is asked to wait in a quiet room, limiting speech, mobility, and exercise to minimize muscle uptake. After about 60 minutes, the patient is asked to empty the bladder and then position on the table. Exam is usually begun with a CT scan, which takes I suppose maximum a minute, but in reality should take a lot less depending on the number of slices and technology used. And subsequently, the PET scan takes about half an hour. and usually requires about 6 to 7 bed positions, of course, unless it's a United Imaging scanner, which can do the whole body simultaneously. It's really important to remember that the PET study is performed with patients breathing quietly to minimize respiratory motion. Um, since each bed position takes at least 5 minutes, we can't ask the patient to hold the breath that long, so we're going to experience motion near the diaphragm, both above at the lung basis and below in the liver dome. So this is the typical physiologic pattern of FDG uptake. Brain usually is the most intense. It really likes sugar, as you can see. I have also observed that by giving candy to my own kids, the activity dramatically ramps up after administration of candy, so clearly brain activity goes up. Heart, highly variable, sometimes can be very intense, sometimes relatively low. Kidneys excrete FDG, so we will see activity within the renal pelvises, ureters, and urinary bladder. Muscle uptake will be highly variable, primarily depending on the insulin level. And if you see diffuse muscle uptake throughout the body, that means is that the patient likely ate just before the scan, so the insulin shut up, decreased the blood sugar, and drove it in the muscle, and is driving the FDG into the muscle as well. PET-CT interpretation. In reality, most of the time we do visual or qualitative interpretation. We compare the target lesion to surrounding background, similar tissue, and the reference uptake in the mediastinal blood pool or liver. We can also perform a semi-quantitative evaluation, which is standardized uptake value or SUV, and this is the most widely used and reported method for quantification of FDG PET. It is also important to note is that the higher the SUV, the more aggressive the tumor tends to be. And this has important prognostic predictive abilities. Truly fully quantitative imaging is not clinically possible these days. However, maybe this new United scanner will change that. So it's really important to understand what SUV is. SUV is a semi-quantitative assessment. In general, SUV should be normalized to patient's weight or preferably lean body weight because the patient with cancer is likely to lose fat during the course of therapy. Therefore, unless its SUV is normalized to lean body, it may not be fully comparable during the course of treatment. There were also attempts to normalize it to the body surface area, but that proved to be less useful. There is some work that was done on dual time point PET, where SUV is measured in an initial scan and a subsequent delay. There was some modest impact based on the papers, but that really has not proven to be very, very useful, although honestly we continue to do that just by inertia for certain tumors. There are several ways that we can report SUV. The most often is using SUV max, which is the highest voxel value within the ROI. And the big advantage is it's extremely reproducible because this is done by the computer that simply searches for the highest intensity voxel. SUV mean, which calculates an average value, is much less susceptible to noise, but however is much less reproducible because it requires exactly the same placement of the region of interest. So Rich Wall and his colleagues proposed SUV peak to combine advantages of both modalities. So take 1 cubic centimeter sphere of tumor around the highest and the most intense voxel, and that is called SUV peak. In theory, they should have significant advantages over SUV max, but the software is not that widely available, so most places still continue to use SUV max. And if you look at the publications in the modern literature, again, virtually everyone continues to use SUV max. So these are some examples of SUV measurements and normalizations. Images on the left, we're measuring SUV max using total body weight of 17.9, and when we adjust the lean body mass, it's 14.9. When we're measuring SUL peak, the total body weight is 12.4 and lean body mass is 10.1, and as we expect, SUL is going to be smaller than SUV just because it's an average and not the hottest. And you can see that there is a significant variability in terms of which variable we measure and how we correct it. So if the threshold for response is 30%, just doing a different measurement can easily exceed that. So again, it's very important to be consistent. Just because a lot of people needed to publish papers, there were several proposed to use total metabolic tumor volume and total lesion glycolysis, measuring the entire tumor. And to be honest, it's kind of fun. You can draw, the computer draws these regions of interest, you get these numbers, the contours tend to be pretty good. Papers suggested that these volumetric parameters are probably better, but the advantages seem small, and outside of papers advertising these parameters, nobody uses it in real reality. I think when I first got my hands on the software that was able to calculate it, my personal interest, I think, lasted for about 3 to 4 weeks, and then I got lazy and stopped reporting them. So this is how it would look like using various softwares. It's possible to contour the tumor. So it's really important to understand the parameters that may impact SUV variability. One of them is that different scanners will measure SUV differently. There's no perfect correlation. So if you have multiple PET-CT scanners, it's important that each patient, when they're getting follow-up, they get imaged on the same machine as they were imaged before to make SUVs compatible. And you can see in this particular study there was quite a bit of variability based on instrumentation and analysis factors. So there are a lot of other factors that play in terms of contributing to SUV variability, and it has to do with quality of injection. So to make sure that there's not a lot of tracer left in the syringe and that the tracer was not extravasated. It's also important to record timing when the dose was calibrated, when it was injected, when the patient was actually imaged. And in the United States, we can't make trains run on time, so what makes this thing we can make the injections run on time. So this is probably a significant source of error. Scanner variability, as we mentioned, different volume averaging effects for measurements, as well as, of course, there's always intra and inter-observer variability. This was a really neat study from MD Anderson of looking at the doses left in the syringe after the injection, and you can see that in one particular case over 2 millicuries was left in the syringe, and that would have tremendous impact on calculations of SUV max, because we do need to know what was actually injected. So very, very important to train technologists to prevent extravasations and to accurately assess what is left in the syringe. Other factors that can impact use of CT contrast agents, high-density metallic material will result in incorrect measurements of SUV max, as we will illustrate. This is a patient that underwent PET-CT, the images on the left, whole body, and images on the right, the dedicated images of head and neck after administration of IV contrast. On the non-contrast images, we can clearly see the tumor, and we can measure the SUV max of 6.2. On the post-contrast images, we see the tumor way better. However, the SUV max is 10, and this results in inappropriate attenuation correction from increased density of the tissue in post-contrast images. So in this particular case, the difference is 38%, which is rather substantial. So it's really important that in assessing treatment response, we don't compare non-contrast images to contrast images because of the attenuation corrections tendency to overestimate SUV max on the post-contrast images. Personally, since I'm not a fan of thresholds, I'd rather see the tumor, so given choice, I would always give IV contrast. This is another example. This is the patient with a tumor in the pelvis, and on the images on the top, we're drawing the region of interest on the axial image, and when we look on the coronal image to the right, we see that the region of interest happens to grab a little bit of the bladder, resulting in ridiculously high SUV max of 79.9. When we redraw the region of interest to exclude the bladder, the SUV max comes back down to a reasonable 9.78. So if when we're drawing these regions of interest, it's important to remember that they tend to be spheres. So we should look at coronal, sagittal, and axial images to make sure that we're not including an adjacent FDG IVID structure. And this is particularly important when we're close to the bladder, ureter, kidney, heart, or brain. Other factors that can play a role: respiratory motion, particularly for SUV max, because it's the single highest voxel value. So this will decrease the SUV max for lesions at the lung bases and in the liver dome. Blood glucose level, as we talked about it, the higher the blood glucose level, the more competing glucose there is, so it will suppress the activity in the tumor. There were several proposals on how to adjust SUV max based on blood glucose level and normalize it. I've done it a few times. It proved to be honestly too cumbersome, so I sort of now do a mental adjustment. But for patients in the research trial, this may become much more challenging. As we mentioned, body size calculations are very important, as cancer patients tend to lose weight during the therapy, so using lean body mass adjusted SUV measurements will prevent that source of error. So this is an effect of motion. So what we see is the lung nodule at the basis. When we look at the MIP images, we actually can't even see it. When we look at the coronal attenuation corrected image, we see it much better. And finally, when we look at the non-attenuation corrected PET image, we see it a lot better. And when we zoom in on the lesion, we can see that it's not a dot, it's more of a vertical line, which makes sense because this nodule was moving up and down with respiratory motion during the acquisition. And when it comes to small lesions like that, and especially in high motion areas, I tend to rely on non-attenuation corrected coronal images that reduce processing and facilitate lesion detection. These images here illustrate the impact of field of view, again using combination of head and neck and whole body images. As we can see that in the top row, on the whole body images, the SUV max is 5, and on the head and neck image, the SUV max is 6. Again, this is the effect of the field of view. And similarly below, we can see various impacts. Reconstruction protocols also matter in terms of detectability. Again, there's the usual debate between the filtered back projection and iterative reconstructions. In general, iterative reconstructions result in better images. However, when it comes to PET-CT, I think this slide may be the most important slide of this discussion. It really highlights why FDG PET works so well. So in this particular study, we compared the tumor before the treatment, after treatment, and then we assessed the reproducibility of change in tumor measurements. So if we look at the top row for pre-treatment, the observers were pretty close. It's a tight curve. Post-treatment as well. On the percent change, the curve obviously widens a little bit, but this is not bad. On images B in the middle, we use longitudinal, we use the RECIST measurement, so the single longest dimension. We can see that the curves are not nearly as tight on the pre-treatment or post-treatment images as the PET. And when it comes to the assessment of size change, again, the curve widens even further, unlike the PET. Now, when we start looking at two-dimensional measurements, we can see that it's not bad pre-treatment, it's not bad post-treatment, but when we look at the assessment of change in size using two dimensions, completely fails, and this is not a line, this is just a cloud. And this is why when I see reports with AP, transverse, and craniocaudal measurements, I want to cry and I start tearing my hair out. And for those of you who have seen me in person, you know that I have no more hair left. And this is exactly the cause. The strongest advantage of FDG PET-CT is its extremely excellent reproducibility between in assessment of the change and between the different observers, and that's why it is such a good tool in assessment treatment response. So for diagnosis of cancer, we primarily rely on qualitative interpretation, but it's also extremely important to understand the tumor biology and what we're actually trying to accomplish. Many different cutoff values have been proposed over time, but none of them really work. And for example, however, and we'll illustrate this. In this particular case, however, we see that we have a big solid lesion with really low SUV max, so it is reasonable to assume that this is not a tumor, and indeed, at subsequent follow-up, the lesion stayed stable, so it was benign. In many articles, I've come across SUV max of 2.5 to use as discrimination between benign and malignant lesions, and this is one of the papers that suggested it. So this was a SNAP cooperative trial that looked at CT and PET in the evaluation of X-ray detected lung nodules. So obviously these were big nodules if we saw them on X-ray, and of course SUV max threshold of 2.5 ended up working because these are huge lesions. So using that cutoff, the PET was superior. However, that doesn't really work in the modern environment where we're detecting cancer in screening studies and looking at much smaller nodules. So in the good old days when we still had bronchoalveolar carcinoma before it was reclassified as adenocarcinoma in situ, we had investigators looking at SUV max of these ground glass nodules and part solid nodules, and what they found is the diametrically opposite. For part solid nodules, every lesion with SUV max of 2.6 or above was actual inflammation because the low-grade tumors have low level of FDG uptake. And again, similar findings of another study where they found that that actual CV of 1.5 was adequate to separate inflammatory from non-inflammatory. So again, it's really important to understand tumor biology and what we're looking at. So if the nodule is ground glass, a tumor will have low level of the FDG uptake, and a high level of FDG uptake in ground glass nodule automatically implies inflammatory etiology, and usually the opposite in the bigger solid lesions. However, cancer always gives us exceptions, and this is one of my favorite examples. This was a patient with colon cancer that was followed for a number of years, and there was a lesion in the left apex that stayed stable in size and kept showing relatively low SUV max, and all of these changes are within the measurement error and usual expectations of variability. However, the lesion ended up growing, so we finally resected it, and after biopsy, and it turned out to be a primary lung cancer that was just slow growing and low SUV max despite relatively solid appearance. So in this case, we're able to make the right diagnosis because of the lesion growth. So just to illustrate a few of these tumors, again, this is a pathologically proven minimally invasive adenocarcinoma, and when we look at the PET image, we see essentially nothing. And on the CT, this looks ground glass. Another example of minimal invasive tumor, again, we see virtually nothing on the PET image, even with aggressive windowing, and this proved to be a relatively low-grade lesion. As opposed to a more solid lesion with intense FDG uptake, then pathology shows that this is a much more aggressive tumor. This is an invasive adenocarcinoma. Another example, big solid lesion with intense FDG uptake, and pathologically this is an invasive adenocarcinoma, so we see a lot more of these ugly-looking blue cells. Again, another example of invasive adenocarcinoma. We see intense FDG uptake, bigger lesion, and pathologically, again, we see a more aggressive tumor that tends to be invasive. It's also important to understand that in most tumors, SUV max correlates pretty well with the prognosis. So I I really think one of these days that in lung cancer we're going to be suggesting mediastinoscopy and EBUS based on SUV max, because I know if I have a lung cancer with SUV max of 25, I know it has to be metastatic. However, if it's a lung cancer with SUV max of 2, there is no way it has developed metastasis in most of the circumstances. This is an example with breast cancer, a patient on the left. This is an aggressive breast cancer with high proliferative index of 76%, and we can see high SUV max, the tumor is readily apparent. In the patient on the right, we see that the proliferative index is 10%, and the tumor is essentially not visible on the PET-CT. So the proliferative index correlates very well with SUV max and the tumor aggressiveness. Staging, this is a very common application of PET-CT. Once we have a suspected cancer and we're planning a biopsy, or we already biopsied and know it's a cancer, now we're using we're using PET-CT to stage the tumor, be it a lung cancer, be it a pancreatic cancer. And in many circumstances, PET-CT can reveal unexpected or unsuspected metastasis, preventing potentially unnecessary or harmful surgeries. However, PET-CT will never be as good as pathology, which is why in circumstances like breast cancer, when we can easily sample the lymph nodes, the patients do get sent on a lymph node dissection. In the lung cancer, this is more complicated depending on the center involved. The patients should generally receive mediastinoscopy and EBUS if available to look at the lymph nodes pathologically prior to resection. Treatment response, there's a variety of response criteria. Most of the criteria use PET as evidence for presence of a tumor or development of new lesion, not SUV max. However, there are metabolic response criteria as well. DeVille, which is used as a part of Lugano criteria, uses visual assessment of FDG uptake to assess response to lymphoma. And the proposed tumor response criteria for PET, PERSIST, use SUV peak to assess the hottest lesions between the scans to determine the treatment response. One really neat concept that was proposed by Dr. Wall a number of years ago is using PET scan early in therapy to determine whether the treatment is going to be successful. So this is an example of lymphoma where a typical patient will get 6 cycles of R-CHOP. And if you image after the 6 cycles, you really don't know whether you're in the curve A and you cured the patient, you're in the curve B and you also cured the patient with your 6th cycle, or in your curve C where you just brought the tumor below the detection threshold. So Dr. Wall's proposal was to image after 2 cycles. And if we see the tumor, the treatment is not going to be successful by 6 cycles. But if the tumor has responded sufficiently well to bring it below detection threshold, the patient will be cured with 6 cycles. And initially, this idea did not receive very positive response, but is now a mainstay of NCCN criteria for treatment of lymphoma. Unfortunately, this concept has not proven to be as useful in other tumors. However, maybe with further research we're going to discover its applications. But in the lymphoma, it has been a game changer. So for DeVille response criteria, again, this is where it's pretty easy. We simply score the amount of uptake by comparing it to the blood pool and comparing it to the liver. And in general, if it's less than liver, it's negative. If it's liver or more, it's positive, which makes it easy. And that's why most of the PET readers really prefer coronal images to look at the PET, because it makes easy visual assessment with mediastinum and liver. So in this particular case, we can see that most of the tumor has melted away, but we still have a DeVille 4 lesion that's more intense than the liver, implying that this patient will not be cured with standard 6 cycles of chemotherapy. So this is a 2014 version of NCCN guidelines, and you can see DeVille firmly written in treatment pathways. PERSIST, this was a seminal paper by Dr. Wall and his colleagues proposing a PET-based response criteria, which is sorely lacking because other tumor response criteria, such as RECIST, only use PET as positive and negative without using SUV max or other forms of quantification, except Lugano, as we just discussed. So, in RECIST, Dr. Wall proposed using SUL peak to take advantage of increased reproducibility as well as diminish reliance on a single voxel. Also set some criteria for what's considered measurable, proposed using 1 cubic centimeter sphere. And in terms of assessing number of the lesions for response, proposed using the single hottest tumor, although this still needs to be validated in large research trials. And Dr. Wall proposed using 30% as the response cutoff for both partial response as well as progression, and of course, new lesion would be considered progression. 30% is an easy number to remember, and again, additional cutoffs were set to make sure that these changes were meaningful. So this is an example of applying PERSIST treatment guidelines. Is that on the image on the left before therapy, we see the hottest tumor in the L3 vertebral body. However, after therapy, the hottest tumor is actually in the T10 vertebral body. And when we're looking at the SUL peak, the change is 20%, 26%, which is below the 30% cutoff. So this is stable disease by PERSIST. So in summary, PET is simple, robust, and reproducible. Fusion with anatomic imaging with CT or MRI is absolutely critical. SUV measurements are much more reproducible than size measurements, but you have to be cognizant of what you're measuring to compare properly. Is it a max? Is it average? Is it peak? Are you normalizing to whole body or lean body? The concept of mid-therapy scans, again, revolutionized lymphoma. PERSIST, again, fantastic proposal with simple guidelines that are relatively easy to follow, but this needs to be validated to become more usable. Post-treatment PET these days has become much more complicated because of inflammation from radiation, as well, of course, as immunotherapy introducing new challenges, but that requires several additional lectures to explain, so stay tuned. Thank you very much for your attention.